But I can't negate that in someone who's C. diff positive, CBER would not be positive. I will tell you that I've had that experience. So there is probably some cross-reactivity with another flagellin of a Clostridia family, for example. And P-ANCA has been around forever, right? It's one of the initial antibodies that have been expressed in autoimmune diseases. But historically, we know ANCA for Wagner's, going back, and we also know a specific form of P-ANCA for small vessel vasculitides, which you have to understand that the actual antigen for P-ANCA and IBD is not myeloperoxidase and it's not proteinase 3. It's actually its own unique antigen. Therefore, it makes it very specific for inflammatory bowel disease. So the notion we can get P-ANCA in any lab is kind of not accurate because you actually need the appropriate antigen to be specific for IBD. So that's come out as well. So overall, this is what we know. This is our landscape. We've got some microbial-driven antigens, actually all of these, and then there's P-ANCA, which is now thought to be also a microbial-driven antigen response. So this is what it looks like. About 20% of Crohn's patients are P-ANCA positive, and if you measure these antibodies, you do, especially in pediatrics, we see a lot of P-ANCA positive Crohn's actually, because a lot of our younger kids present with colitis. And since P-ANCA is a marker of itis of the colon, it makes sense that we see it more often in pediatrics because young onset actually present with more colitis-like symptoms. So a couple of things to remember is that if indeed we are currently classifying patients as Crohn's disease and ulcerative colitis, it's probably a significant oversimplification of classifying IBD. If there's many Crohn's that are defined immunologically or genetically, by calling it one Crohn's, we're missing the boat. And that's what's happening in our clinical trials. We talked about that yesterday with our PEDS group, is that if you're putting everybody with a colon to be able to get anti-TNF, you're missing the point, right? The problem is that we're not stratifying patients based on their underlying immune pathway. We are assuming every patient with Crohn's or UC, because we give it to both, are TNF producers, and all you need to do is suppress TNF. That's completely inaccurate, right? Because we know there's this spectrum of IBD where you have the UC over here, which is pure UC, P-ANCA positive, pure UC. And then you have on this spectrum, pure Crohn's, small bowel. You look inside, it's classic, often ASCA positive. And then you've got the hundreds of patients that lie in between. And that's our struggle every day, is we actually have to start stratifying our patients into those individuals that would benefit from this therapy versus that therapy. And in the work that's being done here, making sure you're not too far gone before you actually implement a therapy. And we'll talk a little bit about using these immune responses to even suggest you should not get this therapy, this class of therapy, whatever the class may be. So in pediatrics, just to show a little bit of PEDS information, what we found interesting is we took 796 pediatric patients from across the country, and we wanted to see, are the prevalence of these markers different in children who get IBD compared to adults? Because we're seeing different patterns when we're measuring them. And why do kids present differently than adults in terms of their disease location and their presentation? And the most significant age group is less than 8 years of age. It's very rare, although we see it, to have a 5-year-old present with classic granulomatous ileocecal Crohn's disease. It's not a common presentation, but what we do see is pancolitis in a 5-year-old. It's not uncommon for us to see that, and most of them are not ulcerative colitis. They end up being Crohn's after all. And there's been some reports that have shown that as you progress through your immune system, maybe it's immature when you're actually 5 and getting your IBD, that you actually evolve and the bacteria flora change and your genetic expression of the disease and your phenotype changes. So in the younger onset group, which is very fascinating, just overall you can see that CBER is actually the most common antibody measured in pediatric patients. That's not necessarily the case in the adult population. And moreover, if you look at the difference between being diagnosed less than 8 versus greater than 8, it's to show you that CBER less than 8 is absolutely the most predominant marker, and that ASCA, which is the most common marker in Crohn's disease, is not commonly seen. So what does that mean? Remember I said that these markers are probably triggered by bacteria. So could it be that the causative antigen and or antigens or causative reason for IBD in the youngest age group is very different than those bacterial-driven processes in the older age group? And this is where these markers are actually helping to start differentiate age of presentation, and clinical phenotype. And you can see as the kids get older, above the age of 8, ASCA becomes a much more commonly measured serology. And we know that ASCA, again, it's the yeast marker, but there's something very potent about ASCA positivity, and I'll show you that when it comes to phenotyping. So this was the first attempt to start to stratify even by age, using serologies to say presentation is different clinically. What does that mean immunologically? And of course, genetically, we just published a genome-wide association study in pediatrics, and under the age of 8 at presentation had a unique new gene identified. So the question now is that gene associated with serology? So we're doing that to look at serologies in all of these patients and doing a genome-wide association, looking at how the serologies divide out with all the genes. So stay tuned to see if we can actually locate the gene that's associated with SIBR and why it impacts clinical presentation. So why do we care? You've seen this slide probably a million times because it kind of correlates also with what's being done here, is why do we care about stratifying patients? Like, can't we just let them be and let's see how they do? And is Crohn's really that bad? If you would ask the community physicians who send their patients on Pentasa, right, they would tell you, we don't see what you see. We don't see patients who actually develop strictures and penetrating. I don't know why you're pushing biologics on day 1, etc. Well, the problem is that you're not really seeing what we're seeing. We're seeing your patients who have now progressed and who are worsening and ending up at tertiary referral centers, or who have progressed before your very eyes on Pentasa or steroids, whatever the case may be. But what you have to understand, and this is what I can't imagine, that every community physician is only seeing the 20% of patients who never end up with a complication. That cannot be, right? So the reality is, if you look at the natural history of IBD, yes, about 8 out of 10 patients will present unstrictured, uncomplicated, very boring inflammatory bowel disease. But then over time, you could see in this light blue area that essentially only about 20 or less than 20% of patients end up non-strictured, not penetrating, which means the majority of your patients will either stricture or will penetrate over time. The question is who? And some people may say, who cares who? If the majority do, just overtreat those small percentage and just take the loss of it. It's not as easy as that, the reality. I mean, we actually get challenged a lot by saying, why do you care so much? Just treat everyone, right? It's an aggressive disease. Those 15%, so what? They'll get good treatment? Yes, they may not have needed it. But the real question is, can we just separate and start to stratify patients into those with mild, moderate, and severe course a priori, meaning at diagnosis, can we actually start to make those decisions? So this is what the natural history, and what we also have to recognize is this is the natural history before biologics. So this is, if anyone says what will happen, this is what it looks like. And it's also before regular use of immunomodulators. The Europeans were using 50 milligrams of azathioprine, which in a 70-kilo person is completely inappropriate. And unless they're TPMT homozygote, really deficient, it's an inadequate dose. So the reality is that this is what your disease looks like on steroids and mesalamine. So you can talk to your patients about that and say, and if they say, do you have natural history data on if I didn't go on any of these, what would my disease look like? Classically, this is what I talk to them about, that 8 out of 10 over a 10-year period will end up with a complication that likely results in surgery. And our surgical data looks the same. Pre-biologic and pre-immunomodulator aggressive use is that over time about 70 to 80% over a 10-year period need surgery, about 10% each year cumulative.